My name is Yifan Tu. I am a medical oncologist, hematologist. I work at Southeast Health at Cape Girardeau, Missouri. In my practice, I treat solid tumor and malignant hematology and benign hematology. I have been at Southeast for almost 3 years. Before coming to Southeast, I was working at St. Louis University Hospital in St. Louis, Missouri. I worked there as a breast cancer oncologist for 4 years. So I graduated from the fellowship program at Montefiore Medical Center, Albert Einstein College of Medicine at New York, Bronx. So I have been in this oncology field for a few years, and I have a special interest in breast cancer and in lung cancer. Thank you. My management of Neratinib in the first month, I usually start with lower dose and then escalate every month. But sometimes I do use the very low dose, like so 3 pills or 2 pills even to start with, and then escalate slowly by 1 more pill a week per week, and then slowly go up to the full dose of 240 milligram per day. I also use the anti-diarrhea medication prophylactically, so either loperamide or lamodial or colestipol or budesonide. I use all these medication either together or one by one, adding one on top of the other. So by using this strategy, usually I can safely start the Neratinib and then go up to the full dose within 3 months. The diarrhea will slowly stop within 1 to 2 or 3 months. So the unmet need is, I think, in the high-risk patient with positive lymph nodes, larger size of the tumor, when they already completed neoadjuvant chemotherapy, surgery, and they didn't get good response, like not achieving PCR, then we can use TDM1 according to Catherine trial, or pertuzumab plus trastuzumab according to affinity trial. But still, some of these people can still recur. The other unmet need is those people with who has not achieved PCR. Some recur in the brain, the CNS, and in the Catherine trial, TDM1 actually did not decrease the CNS recurrence rate. So that is the unmet need. I think in this area, especially in the CNS recurrence, Neratinib can play a role because it's a small molecule. It can go to the brain to prevent the CNS recurrence. So I think if I believe that the patient has a high risk of CNS recurrence, or if I believe that the patient, even after 1 year of TDM1 or pertuzumab, trastuzumab, they still have a good chance of recurrence, I do add on Neratinib. To manage the patient who have not achieved PCR, That is challenging because I can, as I said before, I can use 1 year of TDM1 according to the Catherine trial, which does decrease the recurrence rate relatively 50%. So there are people even in this group, there are people who still recur. So as I said, I will give TDM1 for 1 year, and afterwards, if the patient has hormone receptor positive, lymph node positive disease, I will give the second year extended, Neratinib trial according to Extenet. I do believe there is an unmet need here because there are still people recur. The most important criteria for using the second year Neratinib, to me, it is hormone receptor positive. Second thing is lymph node positive, especially if the lymph nodes more than 4, 4 or more positive lymph node. Residual disease after chemotherapy, after the neoadjuvant chemotherapy. These are major criteria that push me to recommend the second year Neratinib treatment.